very much for your kind invitation, and as I said, an honor to be here. Can I start by telling you a story? This story relates to Gillian Astbury, 60-odd-year-old lady who came to our hospital with a fractured neck of femur in 2008. She was an insulin-dependent diabetic, and throughout her admission, people failed to prescribe insulin for this poor woman. She was transferred from one ward to another, where a series of doctors, nurses failed to find that this was missing. And you can imagine her blood sugar level started at 7, went to 14, went to 21, went to 49, went to 68 over days. She sadly died following a diabetic ketoacidosis. The action plan that was produced by the legal department at the time is fantastic. It's absolutely brilliant. There's nothing missing from the action plan, including the fact that we did not declare this as a serious incident. Now, this case comes to inquest last year, and our chief exec then said, how can you assure me that all the actions that are in the action plan were completed? Sadly, none of them were. And that's what alluding to the point that Mike earlier on said, that we were fantastic at producing action plans, but nothing happened beyond that. So that's the context that I want this talk to be listened to, in terms of the fact this is all about patients and nothing else. Now, I'll give you my personal recollections of starting in a new trust, because I came from an adjoining trust. And some of these may overlap with what Mike said. So yes, there was an internal focus on targets and performance. Performance as judged by meeting the cancer target, A&E target. And the clinicians would tell you that some of the operational agenda overtook the clinical agenda. Now, despite the Healthcare Commission report, which was pretty damning in terms of the culture of the organization, there were significant pockets of denial in the organization, that people felt this was not us, we were unlucky. Could happen anywhere else in the NHS, why did they pick on us, etc. Now, if you look at the telltale sign, and the warning signs were there all along, yet the failure to pick them up was, as Mike alluded to, where was sort of the board in it? What was the assurance that the board was seeking from internal ideas into the internal complaints issues that were coming up? Staffing levels, you mentioned already, one of the key findings was there were inadequate nursing staffing levels. And I think one of the questions that was asked earlier on, I think the nursing staff got a very poor hearing, and I think unfairly so. The question for me was, where were the doctors in all this? There is a corporate responsibility to look after patients. Where were the doctors in all this? Failure to provide training. Now, if you look at the mandatory statutory training options in the hospital, less than 30% of our staff were able to go to statutory and mandatory training. Often they were short-staffed, so they weren't allowed to leave the ward. How can you have a motivated workforce when you can't even train them to do the job that you want them to do? Inadequate governance arrangements, Mike's gone into detail. What were the governance arrangements? Where were the complaints being listened to? Why are the letters being signed off and not action being taken? And one of the letters that actually illustrates the organizational culture was related to a 20-year-old young lad who died following an admission, having fallen off his bike because his ruptured spleen was missed. The letter that went out to his dad and mum said, sorry for your loss, but I hope the compensation package takes some of the pain out of it. How callous is that letter? How can you write that sort of letter? Bullying and blame. And as Mike said, what constitutes bullying in some instances is firm management. But there were instances where people felt bullied, that yes, I've got to pursue the targets at all costs, and if the targets aren't met, it's my fault. Now, failure to listen to complaint. There were numerous instances where you actually had the letters from relatives say patients were in dirty beds. Patients weren't fed properly, didn't have pain relief, some basic simple stuff, and yet nothing happened. Try again. Now the working environment, if you walk around the hospital, it's a fantastic clean hospital. It's lovely to walk in. All our visitors say, I didn't expect that. But when you look into the layout of the wards are weird. They are very strange layouts because they've got little blind spots. So to nurse a patient in that ward is very difficult because you don't have the visibility, because you have to go into little corners of the wards, and I don't know who designed the ward, but I think it really needs a major redesign. The other big question in the Healthcare Commission was the equipment that we had adequate? Were the staff trained to use the equipment? And as I mentioned earlier on, if they didn't attend their training, some of the staff couldn't use the equipment that was there. A lot of the equipment was poor quality, unreliable, and out of date. Now, Mike mentioned lack of clinical engagement. Absolutely a huge problem. That you have a consultant staff committee where out of 117 consultants, you end up getting 12 of the malcontents who always are there. So you listen to all those issues and you don't find out what the real issues are. You don't find senior leaders on the ward rounds. Ward rounds became a sort of problem in themselves. In terms of sort of looking after vulnerable patients, insufficient senior involvement, where were the doctors actually looking after those patients that require inpatient treatment? There were patients in hospital for over 160 odd days when the clinicians only saw them 4 times in that stint. How real is that? And that is exactly a reality. Audit. Yes, as mentioned earlier on, that audit is a fundamental part of a doctor's practice. Not only does it say what you're doing now, it also constitutes what you're going to do for the future, how you're going to change practice. Very patchy in the organisation. In certain parts of the hospital was non-existent. MDTs, multidisciplinary teams, were set up primarily to make sure that clinical opinion from different sources is sorted out for the benefit of patients. There were clinicians disregarding multidisciplinary team decisions and doing their own thing. And yet that is all against national guidance. Now, Mike sort of said it's a very insular organisation. Yes, it was. It never looked outside. And it seemed that progress had passed it by. A lot of the practices are so antiquated that you wouldn't believe it. And the networks within the surrounding district hospitals, around teaching hospitals, is extremely poor. That very few of our clinicians actually interacted with clinicians from, say, Stoke or Birmingham or Wolverhampton. Poor prioritisation of sick patients. We had this wonderful concept with the modified early warning systems all over the wards. Healthcare support workers were filling these modified early warning scores, not even recognising the consequence of what they were writing down, because they weren't trained to illustrate what was there, escalate it to the appropriate clinical staff before anything was done. So yes, we have ticked the box, we have an early warning system, yet it is useless. Poor communication between doctors and nurses. Well, as I mentioned earlier on, I think the nursing staff got a very poor deal from the Healthcare Commission, because I think what the Healthcare Commission failed were the medical responsibilities in patient care. And I think Colin and I have this wonderful discussion on a regular basis. One of the biggest mistakes we made in the healthcare system was to start calling the ward sisters, the charge nurses, ward managers. I think we actually emasculated, we took out their professional duties, because you are a nurse, you do a professional job. During my training, that nursing on the ward, they were fantastic. You worship the ground they worked on, because they cared for the patients. They made sure the junior doctors that came to their ward did what was meant to be done, and did it properly, and had total support from the consultants that they worked for. Staff factor, attitude of staff. Patients were seen as a nuisance in some parts of the department. Some of the attitude was totally dismissive. And in some instances, when you hear some of the stories, it'll actually make you cringe. How can you become so uncaring when you are the caring profession? That applies to doctors and nursing staff. Inadequate supervision, it was non-existent. In some parts of the hospital, supervision didn't exist. There were supervisors. Some of the doctors in my hospital hadn't had an appraisal for 3 years. Yes, the NHS appraisal system is there, but it wasn't being done. This poor practice, how do you become blind to poor practice? How do you actually ignore poor practice? You know it's going on. You know these patients are in hospital, as I alluded to, 160 odd days after having a relatively straightforward procedure with the average length of stay should be between 6 to 10 days. Why aren't these people being highlighted? Who actually on the ward, there are nursing staff, other consultant staff. Why is it not being highlighted to anybody on the clinical front to deal with it? Poor compliance with basic standards. Again, I'll tell you a story about that, because first thing that happened in the trust was there were 2 serious incidents related to head injuries. And one of the big criticisms was that the consultants weren't following NICE guidance. So the trust board quite legitimately asked, why aren't the doctors following what is national guidance? You go back to the clinicians, they say, well, it's not compulsory for me to follow because guidance is guidance. I can interpret it the way I want to. And then you start issuing edicts to say, I'm sorry, from now on it's no longer guidance, because if you fail to comply with this, you will be held to account. So that's changed some of the culture. But previous to that, it's guidance, so why should we follow it? Now, why don't we learn? This is a summary of what Rodney Ledwood did. He's a gynecologist in Kent who mistreated a lot of women. Whole host of errors, problems occurred. Now what I want to pick up on here is, if you look at the third point from the bottom, all clinicians should participate in audit. The Francis inquiry from 2 years ago said exactly the same. So have we learned anything in 11 years? The answer appears to be probably not. And these are major things that happen. It actually says, on-to-one incident forms should be filled in when things go wrong. I illustrated from the Gillian Asprey story, it wasn't done. So what does it take for us to learn and change practice? Bristol inquiry. Once again, if you look at, clinical audit should be compulsory. Now the horror of Bristol still lives with us to this day, and yet we've failed to learn from it. It mentioned that clinical negligence was acting as a barrier to openness. It creates a defensive culture. Why should it? Mistakes happen in any healthcare system because we are human. We will occasionally make mistakes. Our duty is to learn from those mistakes to stop them happening to somebody else. So the issue here is what does it take for us to start learning? Once again, abstinence and helia, another big investigation into NHS care, poor care. Now, what do you look at the last section? Urgent care needs to ensure that staff felt safe to raise concerns. Major challenge for the current government is how do we make whistleblowing? And I hate the word whistleblowing because it actually implies something that you're sneaking about your colleague. How do you raise concerns and still feel safe? Whistleblowing for me is too late. Somebody has come to harm already. So really we should be doing something before that. Why does it take for somebody to come to harm, for somebody to have a corridor conversation with me? The corridor conversations that Michael alluded to now longer, I said, I cannot unknow what I know. So it will be formalized, it will be dealt with. And you've got to come up and be accountable for what you've just said, because it will be looked at. Because you can't actually dump the monkey onto my shoulder and not take any personal responsibility. Patient safety is everybody's business, not just the medical directors or the nursing directors. Now, this is the quality board that was set up in 2009. Very laudable aims. Now, clinical teams should be measuring and benchmarking quality of services and being honest where improvement is needed. What are the quality indicators? Are we measuring them? Yes, we're measuring VTE because it's mandated that we measure it. A&E targets. I mean, you know, the cancer target. But how many of us look to admissions from surgical wards to ITU? Is that not a quality indicator? How many of us measure the number of patients who end up in X-ray departments for imaging procedures following a surgical procedure that's gone wrong? Because these are invisible things, aren't they? How many of us actually look at those two repositories of clinical information? How many of us measure cardiac arrests outside coronary care unit or intensive care unit because we know the mortality outside those units is 5 or 6 times higher? Because that may illustrate the weakness in the systems that we have in terms of have we got the right trained staff, right number of trained staff to deliver resuscitation in an area which is not equipped to deliver resuscitation. So what I'm saying is, you know, this is a list, very laudable aims, but what are the quality indicators? Who's going to define them and who's going to actually measure them? Now, if you find that the quality indicators are not met, what are we going to do to measure them? Measure them and deal with them. So I think in terms of openness, very laudable aims for the National Quality Board, but we've got to say, how do we now make it happen? The challenges to the NHS are, you know, focused on sustaining quality. First of all, we need to define what quality is. And I think Liam said at the very beginning, look at the last one, in the diminishing financial resource. You know, you're going to be challenged, all of us are going to be challenged in trying to deliver healthcare in a reduced financial envelope and deliver quality care. You know, continuous focus on improving services, wonderful, laudable aims. How do we now actually do it? So if you, as the nurse on the ward, find that something needs changing, that the pressure mattress on the ward that's there you haven't got enough of them, and therefore your patients have got no pressure sores, yet the department says we can't afford any more pressure mattresses, where do you stand? Meeting rising demand. The patients are expecting us to deliver healthcare better than ever before because that's what the politicians tell them. Patient-centered care. We are putting all this money into the health service. These doctors, these nurses should be delivering quality care. And so the expectations are high. So we've got to rise up to the challenge to deliver that, but how do we do it within the problem that we currently have? Reducing inpatient activity. Again, you know, care closer to home. New government, new white paper, that's what should happen. The issue for me is primary care ready for all that's going to come their way? Have they got appropriate governance structures to look after all those patients that are currently under hospital care? Because I think the fear for me is that the patients will fall between two stools. The secondary care setting that is no longer commissioned to see them, and the primary care that is ill-equipped to handle them. And that is my biggest fear in the NHS currently, is that all these changes are taking place, and until I'm assured that these systems are in place, the patients stay exactly where they are.